So here we're going to walk through spinal cord anatomy and sensory projections in neuroanatomy. We're going to start with spinal cord anatomy and histology. We're going to begin by distinguishing white matter, which contains the tracts, from gray matter, which is the nuclei. And then we have this simple heuristic here, where sensory items tend to live posteriorly, motor items tend to live anteriorly, and then the intermediate region contains autonomics as well as spinocerebellar items. We can see this in the white matter funiculi. Posteriorly are the large proprioceptive afferents. Laterally are these large motor efferents. And then anteriorly are these small thermo-nociceptive afferents. And then in the gray matter in the posterior horns are the sensory nuclei, whereas in the anterior horns are the motor nuclei, and then in the intermediate zone are the autonomics and spinocerebellar nuclei. Now the other thing what we want to address is the different levels of the spinal cord, from cervical to lumbosacral, from top to bottom, and their relative amounts of gray matter and white matter. So we're going to reason through why these different ratios exist. Starting in the lumbosacral region, we have a thick amount of gray matter. Remember, the gray matter are the nuclei. So why is this? Well, we have a lot of motor innervation of the lower extremity, and especially into the foot, into the fine motor skills of the foot. So that requires a lot of motor input, a lot of motor nuclei, thick gray matter. Conversely, we do not have a lot of white matter tracts, and that's because the sensory fibers haven't yet accumulated. They are accumulating as they go up. The afferents are accumulating as they go up, so there's a thin amount of white matter. As well, the descending motor efferents have already reached their projection, so they've already exited the spinal cord, so they're gone. In the thoracic level, we have a thin amount of gray matter, and that's because it doesn't take a lot of motor innervation to innervate the chest movements. It's not very fine motor. And conversely, then we start to get a thick amount of white matter, and that's because we have all these sensory afferents from the lower extremities that are accumulating, and we still have motor efferents that are descending that will have to hit the lower extremities, those motor efferent white matter tracts. So we start to accumulate a lot of white matter. And then at the cervical level, we have both thick gray matter and thick white matter, and that's because it requires a lot of motor innervation, a lot of nuclear pools to innervate the upper extremities and fine motor skills of the upper extremities. And we have all of the descending white matter tracts still present, and now we've accumulated all of the ascending white matter tracts from the lower extremities, those sensory tracts. And then it's just important to note that generally speaking, the cervical spinal cord is at its greatest diameter, its greatest size at the C5 level. So let's go through these motor tracts themselves. So these are the three key tracts we're going to work through. Posterior column pathway, this is a large afferent sensory pathway. 2-point discrimination, joint position sensation, vibration, all of those sensory modalities are maintained or accumulate in the posterior column pathway. And then we have this anterolateral system, anterolateral because that's its localization, but spinal thalamic tract is a better or a more well-known name for it, and that's because this anterolateral system contains multiple different tracts, but the most notable one is the spinal thalamic tract. It contains pain, temperature, nociception. These are all small, thinly myelinated fibers. Again, it's a sensory tract. And then we have the lateral corticospinal tract, which contains the main motor efferent fibers, lateral because it lives out laterally. So this is our basic setup. We have a mixed spinal nerve, and we're using this as the right side. This is the left side. We're labeling our primary sensory cortex here. We're labeling the thalamus, and then we have this mixed spinal nerve here on the right. And then this is the this is the dorsal root ganglion for both the anterolateral system and the posterior column pathway, those sensory afferents. So we have a 1 here because this is our primary sensory neuron. Next, we have a posterior nerve root, and then we've started with the posterior column pathway. So the first order neuron lives in the dorsal root ganglion. The second order neuron actually lives in the gracile and cuneate nuclei here in the medulla. So that those fibers enter the posterior column, but they don't make a synapsis. Rather, they just ascend all the way to the medulla, where they make their first synapsis in the second order neuron in the gracile and cuneate nuclei in the medulla. And then they make a cross here, their decussation in the internal arcuate fasciculus, go up the medial lemniscus, and then they make a next synapsis at the third order neuron, which is the thalamus, the ventral posterior lateral nucleus of the thalamus, and then they ascend ipsilaterally from that thalamic relay to the cortex here. So they cross from right to left, and this is where they make the decussation. For the anterolateral system, again, the first order neuron is here in the dorsal root ganglion. The second order neuron, however, is here in the posterior horn of the spinal cord, right here. So these fibers actually ascend or descend a variety of different levels. They make a synapsis here in the posterior horn, and then they make their decussation within the spinal cord itself, and this is really important for localization. So you're distinguishing sensory modalities here. The posterior column pathway, the proprioception, two-point discrimination, all ascend ipsilateral along the spinal cord, whereas the anterolateral system, the pain and temperature, crosses within the spinal cord, makes a decussation within the spinal cord, and then ascends contralateral to its site of origin. And then they live here in this anterolateral region of the spinal cord where they make their ascent. And then once again, they synapse in the thalamus here and then ascend to the primary sensory cortex. So the third order neuron again is within the thalamus. But the key distinguishing factor is the posterior column pathway ascends ipsilateral to its site of origin. The anterolateral system, the spinal thalamic tract, ascends contralateral to its site of origin. Then we have the lateral corticospinal tract. Now, here we were talking about sensory afference, sensory input. Now we're talking about motor efference, motor output. So the first order neuron here is going to be in the primary motor cortex. Again, it crosses and makes this decussation here at the cervical medullary junction. And then descends contralateral to its site of origin here to the lateral cortical spinal tract. It makes its synapsis here in the spinal motor neuron, here in the anterior horn of the spinal cord, and then exits as the anterior nerve root, and both of these things meet up as the mixed spinal nerve. So in terms of descending pathways, we're not going to actually go through this in this walkthrough, but we have a whole tutorial that goes through the reticulospinal tract, vestibulospinal tract, and then the corticospinal tract, as well as the hypothalamospinal tract. All of these descending tracts you can learn in detail in a tutorial on the site. We will walk through ascending pathways. So first, the anterolateral system here. So it enters, remember we said that the first order neuron was in the dorsal root ganglion, the second order neuron is in the posterior horn of the spinal cord here, and then it makes its decussation immediately within the spinal cord. It may ascend or descend a couple of levels, crosses in the ventral commissure here. And then we further distinguish within the anterolateral system itself that the arms, the encoding of the arms, lie inner here, whereas the legs lie outer here. And the way that we can remember this is with the mnemonic of a syrinx. So this expanding syrinx here in the center of the cord, so the syrinx grows out of here, expands out of here. The first thing that it's going to impact are these inner fibers, these arm fibers. So we see what's called a suspended sensory level. So if there's abnormality in pain, temperature, sensation, and it's in this cape-like distribution across the chest, just affecting the arms and the chest here, we think about a syrinx, we think about this region right here, because it's growing outward and impacting the arms first in this cape-like distribution. Next, we have the posterior column here. Again, first order neuron is in the dorsal root ganglion. It ascends ipsilaterally. And then we have the cuneate nucleus. We said in the medulla is where it makes its second order neuron synapses. Cuneate for arms, gracile for legs. And the way that we can remember this is that ballerinas have graceful legs for gracile nucleus, so graceful legs, gracile legs, and that's the distinguishing there. And then the spinocerebellar tract, we have posterior and anterior. Here's the posterior, and then here's anterior right here. Okay, moving on to sensory perception. The posterior column pathway ascends ipsilaterally, we see that here, whereas the anterolateral system, the spinal thalamic tract, makes its second order neuron synapses here in the posterior horn, crosses immediately, makes an immediate decussation within the spinal cord. We have the arms, which lie inner, to the legs, which lie outer. And then they make this third order neuron synapsis in the thalamus and the ventral posterior lateral portion of the thalamus. And then the posterior column pathway, as we said, ascends ipsilaterally along the spinal cord. It synapses in the gracile and cuneate nuclei in the medulla. Then it makes its cross in the internal arcuate fasciculus, and then ascends along the medial lemniscus all the way up to, again, the ventral posterior lateral nucleus in the thalamus. And we can see this crossing. So what we're trying to represent here is not only just the crossing, the decussation, but also this twisting of the fibers that happens. So every one of these orange X's represents a certain twist that happens. So in the posterior column pathway, when there's a decussation and the arm fibers cross midline, they also go from being out laterally here to now medially. And we can see when we add in the facial fibers, we'll see what these projections do as they make a twist. So the facial fibers are the most medial. They synapse in the medial portion of the thalamus and the ventral posterior medial nucleus of the thalamus. But then all of these are going to make a final twist. So for instance, the arm fibers in relationship to the leg fibers, as they ascend ipsilaterally, they are lateral to the leg fibers. When they cross, they twist, they are medial to the leg fibers, and then they make another twist when they project to the cerebrum here, and now they end up lateral to the leg fibers. So denote those orange X's as these twisting, and you can see this twisting here with the face. So they start out medially, these fibers do. After they make this synapsis in the thalamus, they then twist and end up out the most lateral of all. We're going to walk through spinal cord disorders as a final tutorial here. Here we're just going to focus on pattern recognition, and we're going to really harken back to that original heuristic of posterior is sensory, anterior is motor. So vitamin B12 deficiency, also known as subacute combined degeneration. It's combined because it combines both the posterior column pathway and the lateral corticospinal tract. So that is the region of interest in B12 deficiency. And then in anterior spinal artery ischemia, we can see that what's affected anteriorly here are the anterior horn cells and then the spinal thalamic tracts, those anterolateral system fibers. And then in Brown-Séquard syndrome, that's half the cord is affected. So one half, all of the different modalities on one half of the cord are affected. Then in central cord syndrome, often syringomyelia, which we discussed earlier, the syrinx, what's affected are the anterior horn cells here, and then also we said those arm fibers of the spinal thalamic tract before the leg fibers, because this is expanding outwards, and the arm fibers are inner to the leg fibers. Then in ALS, amyotrophic lateral sclerosis, this is a pure motor disease. So the corticospinal tract fibers are affected, and then the anterior horn cells are affected. Tabes dorsalis, also known as syphilitic myelopathy, affects this posterior region of the cord. It affects both the posterior column as well as these posterior nerve roots. Now, it's particularly painful because these nerve roots, irritation, inflammation, abnormality of these nerve roots is very, very painful. In contrast, primary lateral sclerosis only affects the corticospinal tracts. So ALS affects both. Polio only affects the lower motor neuron item, the anterior horn cells, and primary lateral sclerosis only affects the upper motor neuron item, those corticospinal tracts. Finally, haven't mentioned yet, but Friedreich's ataxia affects the posterior column pathways along with the dorsal roots, so it has both upper motor neuron and lower motor neuron findings, but then it also affects motor fibers as well, those corticospinal tracts, and then importantly, the spinocerebellar tracts as well. So that's a quick walkthrough of spinal cord anatomy. This is really, really core information for localization of neuroanatomy.